All right, I'm just going to talk briefly about neurologic examination and evaluation. And I want you to use this information from Chapter 3 to do the discussion board on patient history. So when we're dealing with someone with a neurological disorder, it's going to be slightly different in some ways from people with an orthopedic disorder, and it's going to be the same in some ways. And so we'll talk about that on the discussion board. The learning objectives for this section I want you to address are, I want you to be able to define incidence and prevalence of disease and state how they're expressed. So this is our second visit to incidence and prevalence. We talked about it in pathophysiology last summer. I want you to be able to define what a lesion is and describe 3 different classifications of lesions. Given a case study, a brief case study, I want you to be able to identify whether the speed of onset is acute, subacute, or chronic. And then just a simple question here, why is white matter white and gray matter gray? We'll look at that. So a lesion is an area of damage or dysfunction. Very simple definition. Signs and symptoms following a lesion of the nervous system depend on the location of the lesion. So depending on their distribution in the nervous system, lesions can be categorized 3 different ways. Focal, which is limited to a single location. So if you have carpal tunnel syndrome, that is a focal lesion. It's a single location. Multifocal is limited to several non-symmetric lesions. So say you were in a car accident and you had a bunch of injuries, that could be multifocal. Diffuse affects bilaterally symmetric structures, but does not cross the midline as a single lesion. So that could be like a stroke or a spinal cord injury or multiple sclerosis. That's another diffuse lesion. Events that may affect the nervous system and cause neurologic disorders include trauma, vascular disorders, inflammation, degenerative disorders, developmental disorders, tumors, immunologic disorders, and toxic or metabolic disorders. So example of a trauma would be like a car accident where someone gets a spinal cord injury or a brain injury. Vascular disorders can include strokes and heart attacks and atherosclerosis, that sort of thing. Inflammation, well, you know what inflammation is. So some inflammatory disorders can affect the nervous system. Some acute peripheral demyelination disorders like Guillain-Barré syndrome involve inflammation. A lot of the long-term neurodegenerative diseases have an inflammatory aspect to them. Degenerative disorders include things like Parkinson's, multiple sclerosis, myasthenia gravis, things that are going to get worse over time. Developmental disorders include things like spina bifida and cerebral palsy. We will talk about those in the development chapter. Developmental disorders also include things like autism and other disorders that happen during the development of the brain and nervous system. Tumors, a brain tumor or any nervous system tumor can affect any part of the brain or nervous system. Immunologic disorders can be autoimmune disorders. Myasthenia gravis is an autoimmune disorder where the immune system attacks the acetylcholine receptors at the neuromuscular junction. A lot of other disorders have an autoimmune aspect, such as multiple sclerosis and Guillain-Barré. Those all have autoimmune aspects to them. Toxic or metabolic disorders, such as diabetes, which causes peripheral neuropathy, that is a toxic or metabolic disorder that can affect the nervous system. So the incidence is the proportion of a population that develops a new case of the disorder within a defined time period. So we'll talk about the incidence of Parkinson's in a population over the last year. So the prevalence is the current proportion of the population with the condition, including both old and new cases. So the prevalence, we'd say, for the same disease, we'd say this number of people, or this proportion of the population, has Parkinson's at this moment in time. So incidence is new ones that develop over a defined time period. Prevalence is who has it right now, both old and new cases. So the neurological examination has two parts, the history and tests and measures. So the history is a structured interview that happens between the patient and the PT, or the patient and the neurologist. The speed of onset, just like with orthopedic things, can be classified as acute, subacute, or chronic. Acute indicates minutes or hours to maximal signs and symptoms. Acute onset usually indicates a vascular problem, like a stroke, a CVA. That would be an acute speed of onset. Subacute progresses to maximal signs and symptoms over a few days. Subacute onset frequently indicates an inflammatory process. So some of the types of brain injuries that we'll talk about, subdural hematomas and that sort of thing, they progress to maximal signs and symptoms over a few days. Chronic, gradual worsening of signs and symptoms continuing for weeks or years. Chronic onset often suggests a tumor or a degenerative disease. So Parkinson's has a chronic onset. MS has a chronic onset. Lots of different things have chronic onsets. Some things have an acute onset with a chronic carryover, if you want to think of it that way. So a CVA can have acute onset, but then you can have chronic issues resulting from the CVA. And something like MS can have, it can be a chronic disease with acute exacerbations and subacute results of, so there can be a mix of things. In cases of trauma, the cause is usually obvious, like you were in a car accident and it caused a brain injury. And a concussion is considered a mild traumatic brain injury. So in cases of immune, toxic, or metabolic disorders, the speed of onset varies according to the specific cause. The pattern of progression can be stable, it can be worsening, or it can be fluctuating. So usually when we're defining neurological disorders, it is in one of these patterns of progression. The purpose of a neurological examination is to determine the probable cause of neurological problems so that appropriate care can be provided. So for each test or assessment, there's a technique followed by a description of what the normal response and what structures are intact. So in the module there are some videos of a neurologist doing some different tests or assessments. In tests and measures class last summer, you did some sensory testing, and we were expecting a normal response. And we know what structures are affected. So when we have an abnormal response, we're going to get a different response. So some of those videos are really interesting to look at, and you see what a normal versus an abnormal test is going to be. So in the case of diagnosis, the PT or the neurologist are going to ask, is the lesion in the peripheral or central nervous system? Are the signs symmetric on the right and left sides of the body? Is the lesion focal, multifocal, or diffuse? Does the pattern of signs and symptoms indicate a syndrome? And we'll talk about some different spinal cord syndromes. And what region or regions of the nervous system are involved? What's the probable cause? And finally, what's the diagnosis? So, of course, we are not going to do diagnosis in the course of our practice, but looking at this pattern can kind of help us identify clinical patterns. And remember, clinical decision-making is largely based on pattern recognition. So a neurological screening exam has several purposes. One of them is to determine whether there is a neurological disorder present, or whether signs and symptoms are consistent with a given diagnosis, whether a patient requires referral to another provider, and to determine what neural systems require more investigation. So the screening exam is a relatively short exam, and it's kind of saying, where do we need to go from here? So a good example of this is a PT that I work with was doing an evaluation for someone after an orthopedic surgery. They did a neurological screening exam, and they found some signs and symptoms that were consistent with a non-orthopedic diagnosis. So at that point, well, the first thing he did is he consulted with the other PTs in the clinic to see, like, does this make sense? Am I seeing what I think I'm seeing? And they all decided that the patient required referral to a neurologist, and because there are some systems that required more investigation. So the screening exam a lot of times generates a referral. And it turns out this person did have the suspected diagnosis and was able to get help for it because the PT was aware and alert and did a good screening examination. So a comprehensive neurologic examination is sort of the next step. So the screening you're just doing on a basic level. The comprehensive is then what the next step. So it looks at mental status, central nervous system, autonomic function, motor and somatosensory systems, coordination, spinal reflexes, postural control, and gait. So very comprehensive. And it gives meaningful information for planning appropriate interventions. So investigating all that stuff, and often this is done by a neurologist, they're going to decide, does this person need any sort of medications? Do they need any other interventions? Do they need to be referred back to physical therapy? What needs to happen next? So the comprehensive exam gives us that information for planning appropriate interventions. So special tests are usually performed only when specific signs or symptoms are present. So you'll do the screening, you'll do the comprehensive evaluation, and then if special tests are needed, such as nerve conduction studies or electromyelography or something like that, then those are done after the screening. So the categories of neurologic function are mental status, cranial nerves, autonomic function, motor function, somatosensory function, coordination, spinal reflexes, and gait. So all of those are tested in a comprehensive neurological exam.